now be demonstrating the injections of the elbow. We're basically concerned about the lateral epicondyle area and the medial epicondyle area. The lateral epicondyle contributes to lateral epicondylosis through the attachments of the common extensor tendons of the forearm. This is a common condition that we find that it responds quite well to prolotherapy injections. It's important to mark our anatomy, finding the lateral epicondyle, which is of course the lower part of the humerus. And again, careful palpation around this area is very important to find out exactly what portions of this are tender. We then come on down and we feel the space between the radial head and the lateral epicondyle. The radial head lying in this area. We can look at that on our model and we can see the lateral epicondyle in this area and the space, which is exaggerated in this model, and then the radial head right here. The extensor tendons attached to the epicondyle. The radial head has the annular ligament, a ligament that lies in a circle over it that allows it to rotate back and forth as we pronate and supinate, the arm. It's interesting to note that when you palpate this area, people point to their lateral epicondyle as the area of pain, and yet if you come in on the radial head and you push the muscle aside and come down on the radial head as well, you'll find that this area is almost always exquisitely tender in cases of lateral epicondylosis. So our palpation is along the lateral epicondyle and then down, pushing the tissue aside onto the radial head as well. It's important for us to remember that the radial nerve runs along the medial side of the radial head down in the groove between the radius and ulna. When we place the hand in supination, rolling the radius outward, it elevates that radial nerve and brings it much more into our plane of injection right here. So in the Hackett-Hemwall text, we observe that the injections are carried out with the hand in pronation to let that radial nerve roll medially so that we don't hit it. It is possible to do these injections with the hand in supination, and I routinely do that, but I think it does raise the risk level of this injection some. The radial nerve can be hit at this level and the patient won't know it, and it can cause wrist drop if that happens. Occasionally, one will suffuse enough xylocaine into the area that you get wrist drop for 20 or 30 minutes and then it goes away. But we have to be careful not to cause permanent nerve damage. Our injections then are carried out by, again, carefully palpating the lateral epicondyle, and with our injections, actually doing tiny, tiny injections, but thoroughly peppering that lateral epicondyle. I have found that the more meticulous I am with my injections in the epicondyle, the better results I get. To accomplish the skin sliding in this area, we would come in with the needle here and then come out to the skin level out of the fascia so the needle will move freely. Skin slide, do another injection, skin slide, do another injection, skin slide, do another injection. We can think of these as injecting in a box around the corners of the box. But we need to remember when we bring the needle totally out of the skin, watch where our markings go quite a ways further up. There's where our last injection was, here's where our first injection was. So that we've actually covered a larger area than we might think by the fact that we only have one needle stick at the point of my finger. When we're doing the radial head injections, I generally do this with the arm bent at 90 degrees, and then I push the musculature medially to push the radial nerve out of the area, and then come downwards, being careful to avoid a medial direction where I might drop off into the medial space and inject the radial nerve, come straight downwards onto the radial head, and again peppering that radial head to cover the annular ligament that rides over the radial head in that area. It's very important when we're injecting the annular ligament over the radial head to push the musculature aside and orient our needle straight down onto the radial head so that we don't slide medially into the radial nerve. So our injection on the model is that we push the musculature aside, and we're coming then straight down on the radial head rather than medially, so that we might avoid slipping into that groove and catching the radial nerve in here. Our direction is, again, in this direction, not medially. If we wish to inject in the elbow, it's a very easy injection to do, and we can either come in from a posterior aspect or from a lateral aspect right into the joint itself. There's a space that one can feel, and if we look at the lateral epicondyle and the lateral edge of it right here, and we come off it, there's a little hole right here, and that's the entry point to go into the elbow joint itself. It's not a deep injection, and we can put 1 or 2 cc's of 25% dextrose into that joint. The medial epicondyle is approached from the same way, and this injection is carried out with the patient lying supine. We then carefully palpate the medial epicondyle, noting areas of pain again on it. The important thing here is the ulnar nerve, which runs in the ulnar groove right here. And so to guard against injecting that ulnar nerve, I generally hold my fingers right on the epicondyle and then place a finger actually in the groove so that I'm not going to slip my needle off into the groove and inject the ulnar nerve. So we would do that by holding our fingers in the groove, and this way we're locking the medial epicondyle in our fingers as well, and we can come right down onto it safely and inject the epicondyle itself. It's very important again to find those little tender areas, and they'll often be very small areas, and be sure that you inject them very thoroughly around that medial epicondyle. Once again, we want to stay out of that groove, so keeping our finger in the groove is a good way to avoid that.